scan, if you want me to speed up and just show you CTs and things like that, that would be good. Okay. So just to talk, I give some basic talk, but it has some good points in it for trauma assessment and management. And it's called ABC. Why we call it ABC? Way to bring in circulation. All more for trauma, right? There's also D&E. Anyone know what D&E stands for? D, disability, yep. Disability means central nervous exam, so brain and spinal cord. And E, exposure. Right? So which you guys don't necessarily do in the field, I don't think, but sometimes we do it in a common thing. Okay, so triage. So at Stanford, we talk about triage, we're talking about priorities of the sickest patient, and with regard to what you have in order to be able to treat them also. So the priorities in triage for trauma go the same way as for an individual patient. So you think of airway emergencies, you think of breathing emergencies, you think of circulation emergencies as which patients are the sickest. So you might have someone who's a little bit hypotensive and a patient that's struggling to breathe. But technically, the patient that has the airway emergency would go first, if you had the expertise to put an airway in. In the battleground in Afghanistan, if a medic doesn't have any kind of instruments to do an airway, but he can start an IV or put a tourniquet on, that circulation problem, if it's bleeding from the leg, might become more important to them than an airway problem. So it depends on what you have and what your knowledge base is too. But at Stanford, we have, as you guys should know, trauma code. These are our sickest patients, and I'll tell you how they qualify: trauma alert and a trauma consult. So when you guys call a trauma code to us, the main thing is they might have some physiologic derangement. Okay, so these are patients that are having some respiratory problem. They're either very tachypnic or they're not breathing at all. So they're having some kind of respiratory distress. They could be hypotensive. They could be unconscious, and that's their blessed from a skill of 8 means you're unconscious. Or they could have severe tachycardia. So there's all physiologic parameters saying this is a sick patient from their trauma. And that they need to have as many people in the trauma bay ready to attend them as possible. So those are the kinds of patients when you're coming in from the field we want to know about, because it even has the trauma surgeon go to the trauma bay. We're required to be there within 15 minutes. And four of our surgeons live here in Darien, actually 3 of them. So they would be following you right down the ambulance, don't we say? Maybe you can tell them what road you're on so they can follow you. And then we have some anatomic things that tend to make a patient sicker no matter what. So if they have severe burns to a great percentage of their body, certainly any gunshot wounds from the head down to the thighs, with the potential for bleeding, we have the trauma surgeon come in. So they also probably need to go to the operating room. They need expertise of the surgeon. And then crush injury, amputations. There's some others too, but those patients tend to be sicker. If we have a patient that, if we have multiple traumas, even if they're not that sick, we want the trauma surgeon in there helping, so that we end up, if we have 3 traumas at the same time, we'll fall under the code, so the trauma surgeon comes in, even if they're not that sick. For alert, when we call trauma alerts, there's the potential to have a bad injury, and these are really this is one of the reasons why trauma centers are made. That we want to have a patient in the right situation to be worked up really fast, so that that patient, if they have a silent, deadly injury, will be found. And when they first were looking at trauma centers, and which trauma centers did well, which trauma centers didn't do well, and having some kind of grading quality to trauma centers, 1, 2, 3, and even having trauma centers in general, they found out that the hospitals that didn't do trauma routinely were letting people who had like splenic injuries, and they kept on bleeding, and they would end up dying, although they had been to the hospital for hours, so they weren't worked up fast. So this whole idea of ATLS, ABCs, is to get the trauma patient through as quickly as you can, even if they look stable, that they're going to get evaluated so that you're not missing some silent killer. Okay. Obviously, the other reason for a trauma center is to help those patients that are on the edge have a chance to survive. So these are kind of examples of our alert criteria. Patients have a fractured pelvis, ribs, you can tell if they had chest tenderness, if they had some kind of tenderness when you push on their pelvis, or if you feel some uneasiness. Usually you can see a fractured femur, either a deformity or a lot of swelling with a lot of pain. We tend to make our elder folks that are on Coumadin, which is the blood thinner, that have a higher chance of bleeding in their brain and bleeding elsewhere for that matter, let them be trauma alerts, because we want to have them evaluated really quickly. Patients at extremes of age, either young children or adults. And certain mechanisms, if you fall 15 feet, if you have a death at the scene, obviously the trauma must have been bad enough to kill somebody, so you could have potentially have a bad trauma too. Motorcycle crashes tend to have worse injuries, pedestrian struck, of course. So we make sure that they have a good trauma response. And if they end up having some problem with bleeding, circulation, or their heart rate is really high, there'll be a trauma code. So on your initial assessment, what's your initial assessment? Anybody? Kind of already talked about it. ABCs, okay? We call that the primary survey. I don't know if you've heard of that before, but we call that the primary survey, okay? So the primary survey is your ABC, D, and E in the trauma bay. But for you guys, at least it's the ABCs and maybe the D's too, right? You're doing a Glasgow-Coma scale in the field, right? That's obviously very important. It's one of the criteria for codes, if they're unconscious or not. So you're doing your initial assessment, and I teach the residents that they should be able to do an initial assessment, A, B, C, and D within 30 seconds, okay? All right, so how do you decide if someone quickly has an airway or not? Yeah, you talk to them, you ask them a question. I tell the residents to be respectful, first introduce themselves, especially if someone's conscious. And ask them, the most simple question first is what? What's your name? Right. And then one other question I think is a good question for a trauma patient. But there's a lot of good answers. Who are you? Yeah, that's a good one. What happened? I like what happened. And there's a reason. How much information can you get out of the patient if they can tell you what happened? A lot. And a lot of information about how they're doing physiologically, right? One is if they can tell you they have memory. So one of the first things that leaves if you had a concussion is your memory of the event. That's the first thing that leaves, right? So if you can remember the event, they probably didn't have a significant head injury. If they can talk to you clearly, does that say anything about circulation? Yeah, their brain's working. So you're not only getting an airway assessment, but you're getting a fact that they can remember and they can talk to you clearly, and that their brain's probably working because they can remember. How about breathing? Yeah, they're talking, and I mean, if they say, my name is Joe, then you might say they have a breathing problem, right? But if they're talking to you pretty clearly, well, you've already done, that's what I mean, you can do your primary survey in almost 30 seconds. First, when you ask the questions, of course, if they don't ask the questions, that they have an airway problem, then you got to move on, okay? And so, we have someone standing right there, ask them a question, get the information quickly. Obviously, some patients like to talk for a long time and have to know when to cut them off. And then take their stethoscope out and listen to the bilateral breath sounds. The only thing that they're supposed to know in breathing is their bilateral breath sounds. Why is it important to know if they have breath sounds or not? Looking for that collapsed lung, because of what's the one killer early on for a trauma patient? A collapsed lung, but one that's under tension. Tension pneumothorax, which we can probably see if I get to it. And so you want to know if someone has no breath sounds or not. It's that simple. Obviously, you're doing your full assessment out there and you're taking more than 30 seconds. You're going to probably feel their chest, feel they have crepitus, see if their chest, they could have a chest injury and have that knowledge passed on. Have that knowledge in your head, you know that something could happen along the way if they have a chest injury. You also have that knowledge passed on to the trauma surgeons when you get to the hospital. But really, in that 30 seconds, you want to know if they have breath sounds or not, because having that collapsed lung can kill them really quickly. Then in the circulation, we have them feel for a pulse. And if they're standing on this side of the patient, where should you feel for a pulse? Patient's like right here. Which one?
Side closest to you?
Yeah, and what do you feel, radial, femoral, or carotid? Radial pulse. Why is it more beneficial to feel for a radial pulse than like a carotid pulse?
Tell if they're confused.
They have better perfusion with a radial pulse. They have to.
Well, they have that.
If you have a radial pulse, you know what your blood pressure should be. If you have at least if you have a radial pulse, 80 systolic, right? And so if you don't have a radial pulse, you usually go to the femoral pulse. What's your blood pressure on a femoral pulse? 70, 60. I'd go for the even number, 60. How about for a carotid pulse? 40. You can have as low as a blood pressure systolic of 40 and still feel a carotid pulse. Well, if you don't feel a carotid pulse.
Right.
CPR, right? Okay, let's see what we got here. So primary survey, 20 seconds. I say you really fast if you do it often, but you don't want to miss things. But you should be able to get those kind of assessments within 30 seconds to know if the patient is in trouble or not. And then of course we get their vital signs. I make the joke at Stanford that it takes them 5 minutes to get their vital signs. I said that one. I said, do all these assessments again before you get your blood pressure, not the blood pressure. I said, it'll be 5 minutes. The nurses started saying, no, you gotta be kidding, all this kind of stuff. Finally, someone said, the blood pressure. I said, how long has the patient been here? It was exactly 5 minutes. I was right. It takes a while for those machines to warm up. But you can you already know if you have a good strong radial pulse that their blood pressure is probably okay. Okay. Secondary survey is what we do a head-to-toe exam. And I tell the young medical students that you can do a toe-to-head exam if that's what you want to do. But usually people go from the head to toe down. You start with the pupils. The pupils are not really part of your primary survey. Because if you need to know if the patient's unconscious or not. If you have pupils that are uneven but the patient's talking to you, maybe they have some eye trauma, maybe they just have uneven pupils, it's probably okay. If they're unconscious and they have uneven pupils, that's telling you a lot. So being conscious or not is the most important thing. And then we do our x-rays and things like that, and then we might have to do some immediate interventions, resuscitation, and do our tertiary survey later on. It's just a secondary survey. This is where I tell where the people will stand, make sure they shout out their exam. Okay, airway. So we have to make sure that the patient has an adequate airway, right? So what are some of the techniques you do in the field to make sure they have an adequate airway? Is it chin lift? Head, tail, chin lift, okay. On trauma, right? You have to be careful about that. At least a jaw thrust. Just because what about the trauma and the airway and the head tilt? Have to worry about their C-spine, right? Okay, so that's always airway and C-spine don't always go together because sometimes it's hard to get an airway when you have to worry about the C-spine. But you do. Okay, so, and then normally if someone is struggling, obviously you want to put some oxygen on them. You establish the adequate airway if they need it, or you have to decide they need a definitive airway. And for the definition for the American College of Surgeons, the definitive airway is a cuffed tube in the trachea. Okay? It's a cuffed tube in the trachea, which I know probably most of you don't have that expertise and do an endotracheal intubation, but you need to decide if someone needs to be there to do that endotracheal intubation. Okay? But not everyone needs that. If you can adequately ventilate them, making sure that they have a good bag mask on them if they're not ventilating too well on their own. Or if they're ventilating on their own, obviously you just need to give them supplemental oxygen. But if you can adequately ventilate them and keep their saturations high, you don't need to have the definitive airway. You want that to be done by somebody else. So really you're trying to decide whether they have an airway obstruction or not. And how can you take care of that obstruction, and do you need the expertise of someone to do a definitive airway? But if you can ventilate them okay, then it's probably better to get them faster to somewhere where they can establish that airway than wasting a lot of time putting the airway that might be difficult. Okay, so the ventilation and maintaining their oxygenation is what's important. But if you have someone that has that expertise and they're unconscious and they could use an airway, it is the one treatment in the field that's probably the most important thing, depending on how long you're transported. Then you might have the patients that have a difficult airway, and then that patient, especially if you think they're gonna have a difficult airway, might be the patient, if you can do adequate ventilation, you wanna hold off until you get to a place where they can manage a difficult airway. Who are the patients that might have difficult airway? Children should have a difficult airway, especially if you haven't dealt with too many of them.
Really big people.
Really big people, really heavy people like me. People who have the big necks or something like that. Who else might have a difficult airway? Facial trauma. So that's a tricky one, because if they're, what is the one thing they're probably choking on if they have facial trauma? Blood. Blood is the most common thing. It could be teeth, but they definitely could have blood back there. And so suctioning might be all they need. Or maybe you need someone to put that airway in there, or maybe that patient's going to be too difficult and you kind of back off and say, if I can get this patient to the hospital, they have the special techniques that we can do to get that airway in. Okay, and some patients need a surgical airway. Oh, there's a dirty thing. Okay. That guy had an RPG go up in his face. Rocket propellant grenade, that's in Afghanistan. Now when you look at that face, and I don't have to show it again for those people who get grossed out, but where was his airway? Did you see any airway there? He got tricked. So he had an emergency surgical airway. There was no one that could put it. His mouth was basically kind of melted by the RPG. So he needed a surgical airway. So someone was there to have that kind of expertise to do that. Where do you put your surgical airway?
Yeah.
What part of the trach do you have? Can you feel it? If I go like that over time, we'll go down, you have your Adam's apple, right? And then you run down your Adam's apple and there's a space, and then you have a microcartilage. It's the only one that goes all the way around.
Above or below?
Above the cricoid, below the Adam's apple. So you with really thin necks, you should be able to feel that pretty good. So that's what we go for. Just in case you're in a restaurant and someone's choking, you know, if you do the Heimlich maneuver. You need to make that little incision there, like a little pen in there. Get an airway. Hopefully it'll get that down slow down. Usually if you get obstruction, it's at the vocal cord. So this is actually below the vocal cord. And typically you could just use a knife. Take the scalpel, you put it in there, you take the scalpel out, turn it around, use the fat part of the blade to make it bigger. And you can probably get a 6-ended tracheal tube in there. Okay? I know that's something that you won't be practicing too often, but if you get an opportunity to jump out of that, it's a nice thing to do. But they have, I think the paramedics probably have kits.
Yeah, they do.
Have
Big
kits,
spikes.
okay? And there was like we call it the Sellinger technique, where you're able to insert the trocar into that same area. And then you put a little guide wire in there, and hopefully you're going down to the trachea. And some of the kits have this little balloon indicator that kind of, as you're introducing this trocar, it either comes up or goes away. I can't remember. It's like a red light, little red dot. And that means that you're in the trachea, and you can kind of slide the wire in there and thing over it. So that's how you do a circular airway. Anyway, you want to know if the patient's talking. Okay, so we talked about what that means. What are examples of bad airways? They're not talking. That's actually a big example. So if they're unconscious, that's a bad airway. Well, gurgling, hoarseness, stridor we call it. Okay, that means something's probably blocking their airway, right? That could be like we talked about from blood. Blood is the most common thing that's going to actually be blocking your airways. If they're unconscious, it's going to be their tongue. Okay. It could be direct airway trauma to the larynx. You see some neck trauma there. It could be a hematoma that's developing because they were stabbed in their neck or they were shot in their neck. It could be the patient has something blocking their airway. It's usually blood, but it could be teeth, I guess. Maybe they were eating at the time. You never know. It could be vomit, for that matter. Yeah. Does the patient have facial trauma? Does he have neck trauma, hematoma? Is the patient responsive? Okay, unconscious patient. And finally, we never want to forget the patient with burns. Okay, patient can have a burned airway, and they sneak up on you. They're usually okay talking initially, and then all of a sudden their airway gets swollen, edematous, and they start losing their airway. That usually doesn't happen acutely in the ambulance, okay? It usually happens when a patient's getting resuscitated. We resuscitate patients with a lot of fluid to give them, because that's what you need to do with burns in order to keep their system up. And then that swelling of their airway starts to get worse if they have a burn in their airway. Patients with facial burns, patients with singed hair, certainly someone coughing up carbonaceous sputum, that's the definition of an airway injury and a burn, an airway burn. So that patient is in trouble. We'll need an airway soon, but usually if they're, again, ventilating in the ambulance, they don't need it right away. Okay? So, oxygen, oral airway, you know what an oral airway is? Okay, that's the thing that goes like that. Okay. Can you put them in conscious patients? No, what's gonna happen to those patients? They're gonna gag and they're gonna vomit. Okay, so the patients that you definitely want are the patients that are intoxicated, semi-conscious, but you don't want your intoxicated patient vomiting on you, because they'll aspirate that. They can't really protect their airway, they're kind of in between. Nasal airway, we try to avoid nasal tubes in general in trauma, especially if you have facial trauma. You know why? You can put it into their brain. If you have a fracture in your nose and the plate that protects your nose from the brain is very thin, if that's fractured, you can put it in nasal airway or an NG tube into their brain. So we usually try to avoid putting tubes into the nose, especially if they have facial trauma. If someone has a gunshot wound to their abdomen, they probably don't have that fracture where they're going to get the tube in their brain. But if they have any kind of blunt trauma, car crashes, things like that, that have facial injuries, we try to avoid that. Endotracheal tube, of course, is the ultimate airway. And of course, you guys probably have LMAs for any other airways so it's either endotracheal tube or ventilated with a bag mask. Okay, well that's, again, if you can do it with a bag mask, it's preferable. There's lots of stuff written out there. The big trauma surgeon is arguing whether it's better to intubate someone in the field or better not. In Los Angeles, they found out that the patients that got intubated in the field had a higher mortality. And in Fairfax County, where I work, we found out the patient that got intubated in the field had a lower mortality. So it depends on the expertise of who's doing it and how fast. At Fairfax, we had just the police, paramedics, and helicopters intubating people. So it's a select group of people that intubate all the time. Whereas a lot of different people that don't necessarily have the skills to do it. Stanford, they do pretty good. So if a patient is relatively stable but needs an airway, they'll intubate them. But even then, if the patient's unstable and they can maintain them ventilation-wise, it's better to get them to a hospital. Okay. So, definitive airway. For airway obstruction, trauma, blood, facial disruption, inhalation injury, neck injury, shock. Didn't really talk about that, but if your brain isn't working too well because you're in shock, your airway's you're probably going to lose your airway. Glasgow Coma scale less than 8. Which one do you think is the most common reason to get intubated? Right, Glasgow Coma scale less than 8. By far, patients are unconscious is the reason to get intubated the most. What's the #1 killer in trauma? Brain injury. Time could be. That's a good answer. That's a good answer. That hurts the #2 killer in trauma, which is hemorrhage. Okay. So usually patients who end up dying from trauma have a head injury. And there's things we can do for head injuries, but if you have a really bad head injury, lots of times there's not much we can do. Okay. But the patients that we hopefully can do something with are the patients that are bleeding to death. Sometimes we can't. Sometimes we can't catch up to them. Sometimes they're dead in the field, so it's a moot point. But those are the patients that the trauma center is made for. Yeah, we do nice things with head injury patients too, but it's the patients that are bleeding in the field that we're trying to get. Okay, so breathing, we just want adequate ventilation, oxygenation. We would check for chest wounds, so blunt trauma, you're checking for crepitus, pain, deformities, and for penetrating trauma, you're looking for holes. Okay, if you could take all the clothes off someone's body, which we do, and they were shot multiple times, and you wanted to count the holes, should your count come out odd or even? Even, right? You need to find 2 holes for every bullet, or find the bullets. That's when we do some x-rays, and we do an x-ray of their chest, do an x-ray of their abdomen. So whatever number we come up with, it has to be even, otherwise you're miscounting. So in exposure, which I have a little slide on that, but the most important thing in exposure is it's very important for gunshot wounds, things like that, because you want to find every hole that you can find. Because if you know where the holes are, you know where the injuries are because it follows a path. Actually, penetrating trauma in general is easy to work up. It's easy to make the diagnosis because you just follow the path. The blunt trauma patients are the ones that you're kind of like a puzzle. You have to figure out where things are. You're looking for press down. Circulation. Okay, we talked about, overall responsiveness, capillary, capillary rear field, color of the extremities. I never see my residents pay attention to that. And for most adults, people in adult age, from teenagers to until they're old, a lot older, it doesn't really matter. But for kids, looking at their color is very, very important. You can tell that a child's in trouble much more faster by looking at their color. Are they ashen, gray? Do they have a weak cry? All kids are going to be crying, right? It's when they're not crying. That's when they're in trouble. And they'll have a pulse and they'll have a heart rate that will get faster and faster, but they'll maintain the blood pressure until they fall off the cliff, especially little kids. And how they look and their color and their capillary rear field is very important to check in small children. Okay, it's the same in adults, and in the elderly, it's the other way around. They will never get their heart rate up hardly. They could be on drugs, they could be on, they keep their heart rate down. Their heart, when you're in the gym and you're working out and you're trying to get your heart rate up, the younger you are, the higher you get your heart rate. So the older folks just can't get that heart rate up so high until they get hypotensive. And so the way they look too is also very important. So we check the radial pulse and femoral, and for in the trauma bay or even in the field, really the most important thing for circulation is to stop the bleeding. Okay, it's so important that we put there twice because I think the American College of Surgeons was worried that they were focusing too much on giving fluids and resuscitating, that they kind of lost focus about stopping the bleeding, and that's the most important thing. And then we talk about resuscitation. Classic is 2 large 4 IVs, assess level of shock, crystalloid followed by blood transfusion. If they needed, check responsiveness, and quickly diagnose the source of bleeding. So they had a big study, landmark study done in Houston, where on odd days they would treat the patients like they were normally treating them if they had gunshot wounds, and they would put IVs in and give them fluid and bring them to the hospital. On even days, they decided not to put any IVs in. They just put the patients in the ambulance and go them to the hospital, and then they would get them to the operating room. So which of those patients did better? The patients who got the IV fluid or the patients that didn't? No IVs. Okay. And so from that paper is where we got scoop and run. Okay, that was the landmark paper in Houston that the whole American system is built on scoop and run. So if you can get an IV in the ambulance on the way over, okay, but you still don't want to give a lot of fluid to a hypotensive patient. Now that was specifically on patients that had gunshot wounds because they have 1-2 major sources of bleeding. And by making them bleed more, by giving them too much IV fluids before they get to the operating room to stop the bleeding, you're going to make it worse for them. Okay? One trauma patient is a little bit more tricky because if they have a head injury and a head injury patient has blood pressure below 90 systolic for an insignificant period of time, they usually do worse. So it's kind of a trade-off. So we talk about hypotensive resuscitation. If you have a patient that's shocky, that you have a certain transport time, you don't know if they're going to make it or not because they need some kind of fluid. If you get that IV in, don't waste time getting the IV in, put the patient in the ambulance, get them to the hospital as quick as you can. But if you get an IV in, we try and say, hypotensive resuscitation, systolic 80 or 90. We don't want them at 130 because they'll bleed more. And the more they bleed, the more they lose their coagulation products, and they go in a system where we can't stop the bleeding because they don't have any clotting anymore. 5 strikes of death. You know, was that like a movie of Kill Bill or something like that? Anyone see Kill Bill? What happens after Bill got hit with the 5 strikes?
3 steps, 4 steps.
It is 5 steps. It could be. What if he never walked? What if he just sat there? Might still be alive, right? But anyway, so there's 5 areas in your body where you can lose enough blood that you can die. Okay. So I'll let you guys decide. Where could you lose enough blood? Femur, long bones are one of them. Okay. Now usually that's a little caveat because usually you don't die if you have one femur broken. But if you have both femurs broken, you can get pretty close. You can lose a liter of blood in your thigh for an average teenager adult.
Spleen.
Spleen, okay, so abdomen, okay. And then I had the guys say, well, how do you find if blood, in the trauma bay, we had to find quickly if there's blood in the abdomen. Do you know how we do it? Touching it with, it's half and half. Actually, blood doesn't necessarily hurt. Bleeding doesn't necessarily hurt in there. If it's distended and hard, you'd be very suspicious. Ultrasound, yeah. Then we confirm it with an ultrasound. We can see the fluid in it. But yeah, give me a couple minutes, I can get there. And then and where else besides the abdomen, leg, where else? Head, you can bleed to death from a head, but you don't usually bleed to death if your skull is fractured. You don't have an open injury because it's the pressure that makes you kills you. Neck will add that all if you're bleeding out. So external, and actually that's the one thing in the field that you guys can control. External bleeding. Okay.
AAA.
What?
AAA.
AAA, that would be, actually you could consider that one is called the pelvis. Let's say pelvis. Pelvis is a big area and that's a retroperitoneum, okay? And so in the trauma bay, the quickest way to diagnose if you have a pelvis that's bleeding is get an x-ray. Okay, check a pelvis x-ray, very quick. The one more area of the body we haven't mentioned. Heart or chest, okay? So the quickest way to see if there's blood in the chest is to get an x-ray. You can see a significant amount of blood. If you have enough blood in your chest that you're bleeding to death, you'll see it. Okay. So there they are. And external. So the external part is very important. You know, I've had like run a gambit of trauma. I might have told you this story before, I probably did. But penetrating trauma right here. Right here. What vesicles do you have to worry about right here, do you know? That's right here, right below the clavicle. Well, the subclavian artery and vein. Big vessels, they feed your arm. Okay? So you get a penetrating trauma right here. How do you control the bleeding? Pressure. Pressure. Now, do you put a big pressure dressing on there and then put them in the ambulance and go? That's not going to work, right? You need to hold pressure. Okay. So, one of my early years as a surgeon, they had a guy in the field. They had an exercise. They used live ammo. They were shooting at paper targets. One guy went behind a paper target. That target was dead, but the guy didn't realize it was dead. He shot the target, and the guy was behind it. They got shot right here. Military. Okay. So he came in. He was white as a ghost. He was already in arrest. We opened his chest so we could get control. We opened here. He had no blood in his chest. He bled out totally external, which is very disappointing because there's so much low pressure. They had a big bulky dressing here, but that's not going to do it. Not on your shoulder. You can't dress the shoulder. So if you hold pressure there, they probably could have saved him. To get to us, we could have saved him. It was a tricky injury, but so many years later in Fairfax, just before I moved up here, so that's about 5 years ago, one guy runs his car into a picket fence. So when he hits the picket fence, one of the pickets went through the windshield and held him right there. Big subclavian artery and vein. So he came in with vital signs because the paramedic or EMT was straddled him on the stretcher the entire helicopter ride and held pressure there. So key point, just pressure. Pressure for external bleeding. Of course, sometimes you just have to hold it. So that guy's his brachial plexus, which is the nerve supply to his arm, didn't do too well. It surrounds your artery and vein, so his arm wasn't very functional, but he lived. So. Okay, so I'm going to get to, this is just levels of shock. I don't know if you learned this stuff, but level 1 is 15%. Your vital signs look pretty good. Level 2, the only really characteristic thing, some things are getting worse, but the characteristic is tachycardia. So if you're tachycardic, you could have lost already a quarter of your blood supply, and those patients are very dangerous because they don't look too bad, but they can sneak up on you. To level 3, that's when they start losing their blood pressure. And those patients, to everybody's eye, look like they're in shock. Okay, so level 3 is pretty obvious shock, but we want to make that diagnosis when they're in level 2 or even level 1. And then, so this guy is going to probably be in shock. I was in Afghanistan twice. That's a minor degree in Afghanistan. And then this is really bad. These patients are about to die, and so you really have to jump on it. Or just about, and if a trauma patient is tachycardic, then starts to get bradycardia, bad sign. That means their heart's giving out, and you might not be able to get them back. But all this other stuff is there, and we had to jump on. They probably even need their chest open before we get to the operating room back. So.
What was the word of the
Oh, altunded. That means they're almost unconscious. Stuporous. The shock is so bad that their brain is shutting off. So pitfalls. We talked about kids. They're all children. They all look somewhat too bad until they fall from such. Pregnant women, they compensate because they have hypervolemia. They have more fluid in their bodies because of the pregnancy, and so they might not look like they're in shock until they fall off the cliff. So be careful with them. The early sign of shock in a pregnant woman is fetal distress, actually. The baby's going to suffer first. And then some of the medications, Coumadin and stuff that are bad for trauma patients. Okay, so we do this. We do responsive center. It's the last technical slide, and I'll show some pictures. Response. So we have 3 types of responses to resuscitation. What do you think they might be? People who respond, so they're responders. Non-responders. And then, so there's a middle category. It's called the transient responders. So responders are people who were hypotensive and they got their blood pressure back and they kind of stay there. Those are good patients. They might have a fractured femur where they lost some blood, but they stop bleeding normally. They could have their spleen injured, but it stopped, their liver injured. By the way, you can die of scalp wounds, so holding pressure on them would be important too. Transient responders are people who continue to bleed. They kind of go up when you give them resuscitation, then they go back down. They go up and down. And then they have the non-responders, people who obviously need to go to the operating room. For the inexperienced doctor, and sometimes the experienced doctor, the most dangerous patient is which one? Transient, because they suck you in. They look good. That's why patients need to be brought quickly. You say you give them something, they look better, but they're going to do it again. And then they get more fluid, and then they do it again, and they're not worked up fast enough. And those are the patients that are very dangerous because they look good and they even tend to send a CT, but they're going to do it again. Okay. And to cut. Very careful with them. Okay, this is a study I mentioned already about the scoop and run. Massive transfusion means that if we think a patient's going to bleed out a lot by their vital signs and the fact that they're physiologically look bad, we put them on the massive transfusion protocol, and which means we give them a lot of blood, FFP, which is fresh frozen plasma for clotting and platelets. So we just jump on it because and that took a while to learn. That's just relatively new. The military helped us out with that. They get blood fast in the war instead of all that fluid. Disability we talked about, we checked their glasses on the scale, that's when they move arms and legs. We want to remove all the clothing and things like that. And so, chest x-ray. So, tension pneumothorax, massive pneumothorax. We just show some pictures. This is a tension pneumothorax. So, here's the lung. You see all these little blood vessels and things like that? this is really clear, because it's all there. And this is along here, it's like a tiny bit along there, okay? So this is under tension. This actually is a delayed trauma. This patient had an intercostal block put in by her husband 3 or 4 days earlier, and he gave her a pneumothorax that kept getting bigger. Most of the tension pneumothoraxes happen immediately because they big holes in her. But she actually was getting progressively short of breath. Lots of tension pneumothorax is easy to even put your diaphragm in. Okay, so chest tube, this is where we put in the fifth intercostal spot. You guys know what this is? Right, you put that over what? Holes, yeah, you put that over holes, gunshot wounds, that's because you're worried about a sucking chest wound, right? So they breathe in, the valve closes, they don't suck air in, they breathe out, the valve opens hopefully, and they might get some of the pneumothorax out. So if you have a hole this big, what do you do?
What's the dress?
Put a big dressing. That actually won't be a sucking chest wound because it's so big, physiologically it's kind of equal to air. Usually they just need an airway.
What are all those spots holding on?
What? Oh, this guy is a shrapnel injury, and this is a stepping on a landmine in Afghanistan. So it makes it a little bit difficult to figure out where the injuries are because these shrapnel marks are also on their belly. The other two, did they get in? Did they not? Did they injure something bad? He did get it from the chest, so that's a shrapnel. That's what a blast injury would look like. Just showing a CAT scan. This is fluid in the chest, blood. Here's another valve here, gunshot wound. Here's some fluid in the chest. So you can see fluid in the chest on your chest X-ray. This looks bad. Look at this. These are the striations of your muscle. This is like air outside this tissue. This guy's lung is so punctured that he's leaking air into his soft tissue. It's called subcutaneous emphysema. Look and see what we can see. Here's a rib fracture here, rib fracture here. This is messed up. This guy's got a flail chest. Lots of rib fractures, fractured in different areas. He probably has needed chest tube. Because he should have attention to pneumothorax, but the holes are so big in his chest wall, it's coming out through the skin. Okay. He's intubated. The emergency department thoracotomy, we kind of talked about this when we talked about who people you could call and rest in the field or not. We don't do it for blunt trauma that often, we do it for penetrating trauma. Here's what an injury to the lung looks like if you open the chest up, fifth intercostal space. This is an injury to the heart, the atrium. This is the left ventricle. Here are the coronary arteries. Okay, so this atrium here was a little bit easier to fix. Atrium doesn't have much muscle. They're kind of just like muscle, thin wall things that you can lift, stitch, close. These are a lot more complex. You try and put sutures through muscle, it just keeps ripping out. So we have to put these little pledges and things. And then you can imagine the blood coming out of the heart that has a hole in it. Other different things that you can get, ruptured aorta. Here's the diaphragm in the chest. See this? So you have an NG tube going in, and the stomach should be down here, but it comes back up here. Here's the patient's where the diaphragm used to be down here. So he punctured it, he perforated his diaphragm, usually from a big blow to the abdomen, blunt trauma. So we get this X-ray, you put the NG tube down for OG, right in the nose, and you can see it in the chest, make the diagnosis. Sometimes you can just see this bubble, make the diagnosis. This is a CAT scan with blood around the aorta. This is the aorta, this is the innominate artery which goes to your, on the right side goes to your head and your arm. And this is the left side parotid which goes to the left side of the head. And there's active blood bleeding here. This is what active bleeding looks like. This is bright color is blood. This is old blood. And this is active bleeding. So that person's in trouble. Here's an aorta. Everything should be nice and like this. There's a little bit of bleeding from there, so this patient has ruptured aorta. And all this is fluid here. This is all clot blood. That's too old. This is blood around the heart. It shouldn't be that thick. And so that patient's in trouble from getting a cardiac tamponade. You inverted tamponade, right? You get blood around the heart. That's usually from a heart wound. Could be from something else, like from blood trauma. But we had to decompress that. And we could put needles in there and things like that. Really needs an operation to decompress that. This is the trachea. This is the endotracheal tube. here's a hole. So this patient had a penetrating trauma, like a stab into the neck, and our CT showed that they had a hole in their trachea with all this air leaking out. All that air shouldn't be there. Here is that subcutaneous air now in the CAT scan. You see it all in the muscle and the soft tissue, and there's air around the lung there. This is what the ultrasound looks like. This is a normal heart, left atrium, left ventricle, right ventricle, right atrium. Here's fluid around there. So that's effusion, which in trauma is probably blood. So we're looking for that. And if they're hypotensive, it could be from that fluid putting pressure on their heart. Here's what the liver and kidney look like on the right side. Here's some fluid, so that's probably blood from trauma. Here's some fluid between the liver and the kidney, so that's what we're looking for. So if you have someone who's hypotensive and has blood in their abdomen, they go to the operating room, because that's all you need to know. It makes it easy. Pelvis, these two things are supposed to be together. They're not, that's your pubis. So you have to get them back together. It's separated out. You also have the fracture up through here. Here's what that fracture looks like on the CAT scan. Pretty nasty, huh? How's it trauma? That's what it looks like in the CAT scan, looking like that. He was bleeding from his pelvis, so we actually had to put, here's a blood vessel that's bleeding, so we actually put embolized with an angiogram. Fractured femur, brain injury. The brain's supposed to look like this. This is white matter. This is gray matter. Gray matter is what the cells are. White matter is the cables connecting everything going down your body. This shouldn't be there. That's just a small contusion. That shouldn't be there. So this patient probably hit their head or was a little unconscious. Hopefully they're okay now. This patient has a lot of blood in the head. That the blood looks bright. That's bad. In fact, that ventricles, this actually, you can't see the ventricles here, but there's supposed to be one of these on each side, so this is all crushed down here. That patient's not doing so well. Here's this ventricle. Here's the other ventricle. That contains the fluid that bathes your brain. You can see it's pushed way over. It's supposed to be on this side. And here's a clot of blood. That's a subdural hematoma. All right? So we have to get that patient in the operating room real quick and relieve that. This is, I actually did this case. I'm a general surgeon. Here I am, a neurosurgeon in Afghanistan. And this was shrapnel to the head. And we had to clean it out because it goes through your frontal sinus and everything. This is a 9-year-old kid. So we took the bone off, and we cleaned everything out, and then we put it back, and I got to use all these fancy little screws and everything like that, and trying to put these pieces back together. So in Afghanistan, I was a neurosurgeon, a true general surgeon. This is what a normal spine looks like. 1, 2, 3, 4, 5, 6, 7. You have 7 cervical vertebrae. Here's T1. Nice and lined up. We look at the lines. 4 lines, one there, one sort of there, one back here. They're all supposed to line up. So you can tell me, does this look bad?
Yeah.
Yeah, it looks bad. This patient is a non-survivor because this is such a horrendous spine injury that it ripped all the blood vessels going through there, going to the head. But they obviously they would have obviously been paralyzed if they survived. But that's a it's such a traumatic injury to non-survivor. This is kind of subtle. This is a picture of that C2 area. There's just a little bit of bone there that looks like it's abnormal. But when we reconstruct it, we can see there's a fracture through C2. We call that actually a tonsillitis fracture. There's 1, 2, and 3. It's a quick spine there. But one is just through the very tip, 2 is through the neck, which is what that is, and 3 is through the body. So number 2 is the most unstable. So they need an operation or so this doesn't look good either. This is an MRI. And here's the spine supposed to go straight up and down, right? There's a problem here. There's a disc back here. It's pushing on the spinal fluid. So that patient probably is paralyzed because any kind of push like that's going to paralyze them. Will it come back? Hard to tell. Depends on how paralyzed they are. And if they get any move back early, all this is damaged here. Okay, that's it. That's what you get.